Good evening, dear colleagues. I'm Véronique Fay. I'm a urologist based in Paris, and I'm very pleased to welcome you at this Euro webinar on the practical management of OAB. Yes. So here is the program of the webinar. I'm very pleased to welcome two of my colleagues, John Hisaker from Maastricht in the Netherlands, and also Arun Sarai, who is urologist based in Hospital in London. And we are going to talk about OAB. The aim of this webinar is to give you some evidence based on literature and also experts' experience to guide you to choose between sacral neuromodulations and botulinum toxin A injections. So first we are going to start with the state of the art of the current guidelines on OAB management. Then Mr. Sarai will go with Botox or S&M and discuss which sequence of treatment is the best. And at the end, John Hisakers will present a case discussion and will explain to us how to optimize OAB management. So you can ask your questions through the Q&A windows, and we will be very pleased to answer them at the end of the webinar. So here we go. So we'll start with the state of the art on the guidelines on OAB management. So as you know, both of the therapies, S&M and Botox, are treatment used in refractory OAB. It means that you're going to choose these options after failure of conservative treatment, including anticlinic drugs. The problem is that the definition of a refractory OAB is still controversial. It means that you can talk about refractory OAB in case of lack of efficacy of first-line treatment, in case of loss of efficacy, or in case of poor tolerance also. And it seems that the most interesting point of view to consider is the one of the doctors above the one of patients, above of the one of doctors and the literature. If we consider the different elements of success of the treatment of OAB, we can include efficacy, tolerance, quality of life consideration, but also the cost of the treatment, the accessibility of the treatment, the quality of the practitioner, but also the patient expectation, which is really the most important. And the satisfactions of patients is the base of an efficiency and a compliance for chronic disease. So if we look at the guidelines, for many years, EAU guidelines position sacral neuromodulation and botulinum toxin A injections on the same level. And if one treatment modality was not successful, the other one may be tried, or even a combination was possible. And I really invited you to review these year's guidelines on female LUTs who were completely changed from the last year guidelines. And we've got really a very interesting parts on how to manage OAB. So if we look at the guidelines, you can see that the EAU states that we have to start with 100 units of ONA botulinum toxin A injections into the bladder wall, which is more effective than placebo to treat idiopathic OAB. However, with these injections who are needed to be repeated, the discontinuation rates are high. And also there is an increase of the PVR volume and the risk of UTIs. And it seems also, and it's a level evidence of 1A, that ONA botulinum toxin A injections at the dosage of 100 units is superior to anticholinergics and mirabegron. And so at the end, the EU recommends to use Botox, because it is the one who's really licensed for that, to treat refractory OAB, and to warn patients, of course, of the limitation duration of the response and the risk of UTI, and also the risk of increased clean intermittent self-catheterization. Regarding sacral neuromodulations, it seems that it's more effective than to continue failed conservative treatment. However, there is no sham controls study. And there is also a very interesting study that I think that Mr. Saha is going to talk about after in this talk, is that SNM is also as effective as Botulinum toxin A at the dosage of 200 units injections at 24 months. So at the end, EAU guidelines recommends to offer sacral neuromodulations to patients who've got refractory OAB, refractory to anticholinergic therapy. But as you can see, we do not give any priority to any of the two treatments. The NICE guidelines is a little bit more different. So the last guidelines were dated from 2019, and they said that first you have to discuss your case after a local MDT review, and you have to perform also urodynamic investigation, which has to demonstrate the absence of detrusor overactivity, and that the patient does not wish to have other invasive treatment. And in case of these conditions, you can offer Botox. But of course, you have to warn about the adverse effects. And you have also to follow up your patients through a face-to-face or telephone review within 12 weeks. You started at 100 units and consider increasing to 200 units if it fails, and review within 12 weeks also. And if you want to offer sacral neuromodulation, it is very interesting because it's quite different, because SNM has to be considered after botulinum toxin A injections. So it's after failure of conservative treatment and after failure of Botox injections. And this is the guidelines for the International Continence of Urological Diseases. So you can see that there is a big flow chart with every types of incontinence, but at the end, they propose botulinum toxin A and SNM without any prioritization, and also bladder augmentations is part of the part of the treatment in case of refractory OAB. And at the end, there is also the AUA and the CFU guidelines, and which really distinguishes which is FDA approved and which is non-FDA approved. Neuromodulation therapies, such as sacral neuromodulation and tibial nerve stimulations, are FDA approved as third-line therapies, whereas botulinum toxin A injections is a third-line treatment, but non-FDA approved. And the patient, of course, must be able, it means that you have to test the patients before, and willing to perform self-catheterization if necessary. And there is this paper published in Neurourology and Urodynamics a few years ago, which was a think tank discussion. It was an international board who discussed about the flow charts of the treatment of OAB, and who also offered PTNS, Botox, and sacral neuromodulations according to patients' or physicians' preference. It means that you have really to discuss about the expectations of as a practitioner, but also of the patients before offering this therapy. This paper published in BGUI discussed about the guidelines of OAB, of the treatment of OAB, and really straightened the differences between the different international guidelines. And it seems really that NICE guidelines is quite a difference from the other. We have already discussed about it previously, and that in same guidelines, you have to teach really people to self-catheterize, whereas in other guidelines, you just have to inform patients about the risk of self-catheterization before Botox. But we are talking, you know, as you can see here, about a very rigid flow chart. You have to offer first-line therapy, which includes anti-muscarinic and beta-3 agonists before, after behavioral interventions. And then in case of failure, you're going to discuss about Botox, PTNS, and SNM. But it's the current flow chart, of course, but is it the right flow chart today? We must say that the discussion now is quite interesting because we are moving toward a profiling of the patients who suffered from OAB. So you know that the pathophysiology of OAB is quite complex, but it includes at least 4 hypotheses. So the myogenic mechanisms, the urothelium mechanisms, but also the infectious pathophysiology. We talk about microbiotes, and also the neurogenic hypothesis. And in addition to these 4 pathophysiology, in addition to these 4 mechanisms, there are also many comorbidities. And you know that most of the patients who suffered from OAB have comorbidities, menopause, obesity, diabetes, metabolic syndrome. And so we are moving through this interesting diagrams that you can find in the European Urology by Benoît Perronnet, and which offers therapies like sacral neuromodulations or Botox as first-line therapy, if indicated, and not similar to this flow chart that you can see at the left of the screen. It means that, for example, patients who is menopause and suffered from OAB, you're not going to behavioral interventions, anti-muscarinic, etc. You're just going to prescribe to her local hormonal therapy. It means that patients who've got a double incontinence, you're not going through anti-muscarinic, etc. You're going to offer sacral nerve modulations as a first-line therapy. So you can see that really the current flow chart will probably not be very exact in the next few years. So I have finished. I think that I'm going now to give the microphone to Mr. Sahai.
Yep, thank you. Excellent. Thank you so much, Veronique. Fabulous talk. I've been asked to talk on botulinum toxin or sacral neuromodulation and in which sequence of treatment. So I'd like to start by thanking the panel and the EAU for asking me to talk. As Veronique said, I'm a urologist based at Guy's Hospital in London. These are my conflicts of interest. So, as we've just been talking, it's pretty important that we understand what refractory overactive bladder is. The focus of this webinar is treatments for that. And what does it mean? Because there's no widely adopted consensus. Do we mean lack of effects of drugs or that the drugs were not tolerated? There's certainly no clinical or urodynamic criteria that I'm aware of. But I think pragmatically, and probably what most of us do in clinical day-to-day practice, we will make sure the patients have failed conservative therapies, fluid advice, caffeine reduction, etc., and had tried some medications, most likely antimuscarinics and beta-3 agonists, but also maybe different modes and perhaps even combination therapy. As Veronique suggested, this think tank is actually 7 years old, but it's actually something I've been using since then because I think it's quite important to tailor to the patient that's in front of you. And what's become very apparent is that many of our patients will already be on antimuscarinics but from different classes of drugs. So it's important to ascertain, for example, their antimuscarinic burden. That may influence what I do. I may not then add to it, and I may start the patient on mirabegron first line. So I think it's quite important. Certainly, we felt that the refractory OAB options are all equivalent. And what was important for us, and what the key of sort of emphasis I want to put in my talk, is that it's all about the patient. I think it's our job as clinicians really to inform about what the options are. And really they are Botox, sacral neuromodulation, PTNS as well. And in the future, we may even be seeing implantable tibial nerve stimulators. But at the moment, the data for this is a bit weak and we need a bit more maturity. I mean, I can't speak for all aspects in Europe, but certainly in the UK, depending on where the patient's seeing, it will influence what treatments are on offer. So it's very important to understand who offers what and where. And it's very important, I think, that if the patient wants to consider, for example, neuromodulation, but it's not being offered at the center where the patient is, that patient should be referred if that's what they want to be considered for. So the counseling is very crucial. And it's very important that we aid this direct patient history and discussion with decision aids, information sheets, and visual aids. So if we just look at this small table I've generated about Botox and neuromodulation, both treatments have been around for decades. I mean, Botox has been popularized in the late 90s and neuromodulation in the late 80s. There are some obvious advantages and disadvantages to both. Botulinum toxin can be administered under local anesthetic in outpatients. It's a relatively quick procedure and very simple to learn. On the other hand, sacral nerve stimulation is a bit more technical, but it's still minimally invasive. Now, depending on the techniques, whether you do a first stage tying lead procedure, which is what I do, they tend to be in theatre. And so you need 2 procedures under sedation. But PNE is possible where the leads are placed for the trial in an outpatient setting. The duration of effect of Botox is predictable. If you've got a good effect and it's worked, then it tends to last for between 6 and 9 months, whereas the neuromodulation effect is longer. The adverse events are very different. So this is very important to discuss with patients. With botulinum toxin, there's a risk of voiding dysfunction needing intermittent self-catheterization, and there's a higher than perhaps thought risk of UTI. With neuromodulation, there's risks of infection. Lead migration will lead to lack of effect. There's a chance of revision surgery, especially if there's infection or explantation. Some pain is possible at the battery site or at the lead site. And there's a phenomenon of tolerance that large volume, high experience neuromodulators will be aware of. It's not exactly clear because the lead may not have migrated, but the effect somehow is lost over time in some cases. There's excellent data for both of these treatments. There's a very large volume of level 2 data, level 3 data, but even with botulinum toxin, I think there's a considerable number now of level 1 RCTs placebo controlled. I think like Veronique said, there's much harder to do that in the neuromodulation field, mainly because of the problems with sham. Botulinum toxin is licensed for idiopathic overactive bladder wet and neurogenic detrusor overactivity. And sacral neuromodulation is also approved for overactive bladder and voiding dysfunction. Both have other advantages. For example, botulinum toxin can be used to treat bladder pain, bladder oversensitivity, and even voiding dysfunction, but it's all unlicensed. With neuromodulation, it can be used to treat combination urgency incontinence and fecal incontinence. The good thing as well about neuromodulation in the last 5-7 years or so is we have finally some innovations in technology. So we have smaller batteries, rechargeable batteries, and finally MRI compatibility. So there's only one randomized trial, which is level 1, comparing both therapies. And really, I won't dwell on this too long, so I know John's going to talk briefly about this in his talk. But in this only one-off trial, as Veronique mentioned, the Botox dose was higher than the licensed dose of 200, but the responders were equal at 2 years. 83% had responded to the Botox, 84% to the neuromodulation. And the primary endpoint was urgency incontinence, which was no different between the modalities at 24 months. Of note, though, the dry rate was better in Botox, which was unusual because a lot of the other level 2 studies in neuromodulation would suggest that the dry rates were better. But in this particular study, Botox was better than neuromodulation for that. So how else can we help our patients? How else can we tell them, we've told them all this. Are there anything else that as clinicians we can say, oh, well, maybe we should push you more towards neuromodulation or perhaps towards botulinum toxin? So there have been some predictors of good effect or poor effect. And our group have looked at all the data here, published a systematic review in this arena with botulinum toxin. We whittled down the search to 17 studies. What we were able to demonstrate was that men and increase in age were predictors of a poor response, and certainly very high pressures during filling cystometry and poor compliance were predictors of a poor response urodynamically. With regards to some of the adverse events like intermittent self-catheterization use, again, male gender was worse than women and increased in age. And also if your residual was higher than 100 mils at baseline and poor flow rates. With regards to urinary tract infection, men with prostates were worse off than if you'd had a radical prostatectomy. And in general, female gender was worse than men. And if you were performing intermittent self-catheterization already, your risk of UTI was higher. The Maastricht group did something very similar. This is another systematic review in the neuromodulation arena with much more studies. In fact, they included a lot of abstracts, so they ultimately included 78 papers for this analysis. What they concluded was that women and younger patients, and if you had a tie and lead procedure, you are more likely to have a better outcome. But as with the botulinum toxin systematic review, the problem is that the majority of the studies used in the analysis were essentially of what we would suggest is poor quality, level 3 evidence. So really, is that useful to counsel patients? I think it gives us an idea, but I think we have to be very cautious about the interpretability until we have better quality studies. I was also asked to talk about sequencing. Does it matter if you choose Botox first or neuromodulation or vice versa? There's more data actually involved in the use of neuromodulation after Botox. And I suspect that's because a lot of clinicians or patients may go for Botox because they perceive it as a more simple operation, simpler procedure. And so I think the data there is a bit more robust. This is another systematic review, but this time from China, 7 studies included. What they were able to demonstrate is that if you use neuromodulation after Botox, there were significant improvements. This other forest plot here on the right actually looks at data where neuromodulation was done as the primary treatment versus if it was done after Botox. And what they were able to demonstrate in those included studies was there was no difference. So it didn't matter if you were doing neuromodulation first or after Botox. What about the other way around? This is a nice multi-center study from France looking at the effects of Botox if you'd had sacral neuromodulation first or had failed neuromodulation. What's important to know here is that 12% of the population still had their SNS device active. You can see there were different botulinum toxins used, either Dysport or Botox, and different doses. The reason you see 50 units is, if I'm correct, in France, that is one of the starting doses for the licensing in France. There were improvements again in overactive bladder, incontinence episodes, and urodynamic parameters. But interestingly, this was what I liked about this particular study is they followed up the patients for a long time. So the ultimate success rate was only 44–45% because that's with long-term follow-up. So it's quite good that they followed up these patients for a number of years after the procedure. Both treatments, Botox and neuromodulation, have got good published long-term data. This is the follow-up from the EMBARK licensing trials. You can see 6 rounds of Botox with equal efficacy. The primary endpoint of this paper was reduction in urgency incontinence, and the magnitude of that was similar after the 6th Botox injection as it was for the first. Patient satisfaction was equally good after 6 injections as it was after the first, and quality of life is maintained. This is a equivalent, in fact, it was a post-marketing FDA study from the United States, again, multi-center, but prospective, so good quality on 5-year outcomes of neuromodulation, what I'd like to think in the modern era. And here we were able to, again, to show excellent outcomes, 82% responders at 5 years compared to 86 at 3 months. So really showing that this is a durable treatment. The improvement in incontinence was also maintained, as well as the quality of life, as can be seen on the diagram here using the ICOL questionnaire. These are the adverse events in a modern series. So infection rates, I think, have come down. It was 4% in this particular study, but useful data to quote: permanent explantation in around 20%, and 20% reintervention rate at 5 years for whatever reason, battery change, infection, lead migration, etc. And again, the dry rate was better. I mentioned that the Rosetta study was quite low. In this particular study, the dry rate was around 50%. What about discontinuation rates? Our unit published this about 10 years ago now. Our experience has been slightly different. This was prospective data, and our feeling with Botox injections is that if you made it to round 3, you were very likely to stay with the therapy. So the first 2 rounds is where we saw the drop-offs, about 25% in both times. And the main reason for the drop-off was they didn't like intermittent self-catheterization, or there was a lack of effect. Those were the 2 main reasons. But otherwise, patients stayed with the therapy. That has not been the experience of some of my colleagues who have reported in a retrospective fashion higher discontinuation rates with the therapy. So in conclusion, I think it's critical to get the correct diagnosis. What do we mean by genuine refractory overactive bladder? It's really important to discuss all the options, in my view, to the patient, and the patient must decide what they think they want. And we have to be honest about the evidence base, about the risks, the benefits, and I think it's important the patient decides. They have to be given the appropriate information. If you don't offer that treatment, the patient needs to be referred to where the treatment is offered. I don't think sequencing matters too much, but we have much better data of the use of neuromodulation after botulinum toxin than the use of botulinum toxin after neuromodulation. So perhaps we need a few more studies there. The long-term results are generally good. I haven't spent a lot of time on the neurogenic side today, but there's certainly more evidence base for neurogenics in botulinum toxin, but the neuromodulation evidence base is improving. There's a number of trials running in Europe that will report soon. And me personally, I would, in highly selected MS patients, for example, use neuromodulation. Discontinuation rates can be a problem with the Botox therapy, but then so can tolerance for neuromodulation. So they have, again, unique different benefits and pitfalls. Thank you for your attention. And I just leave you with this summary slide, again, re-emphasizing the doctor-patient relationship. And really, for me, it's about the patient deciding. Thank you.
Thank you, Arun. So now we are giving the microphone to John Hisakers. Please, John.
Thanks very much, Veronique. Thanks very much, Arun. Yeah, so I think we heard that we have very solid guidelines. We also have very solid data from as well botulinum toxin studies and sacral neuromodulation studies, although, of course, it is not that easy to have huge trials on surgical treatments and indications. So we lack some data, but still we need, we know something about all these treatments, and therefore we can also use this in clinical practice. Now, I'm going to share with you a case which is very straightforward, that you might encounter these patients in your practice, and then you always have to make a choice. How am I going to treat this patient, and what will be the benefit and what will be the drawbacks of this? So now I'll start sharing my screen. And it is an interactive case discussion. I know it's not that easy to do that in a webinar, but I suggest that when I have some kind of a question to you, that you write something in the chat. Don't be shy. And then I will ask Arun and Veronique to look at that and also have some answers ready, because we're all in this together. These are my conflicts of interest. And we go to Mrs. Robinson. Perhaps you know her. She's a 50-year-old woman who went to her general practitioner with overactive bladder complaints, and that consisted mainly of urgency and urgency incontinence. She is the second wife of a retired lawyer, and she has some hobbies like tennis, reading, and she takes care of her grandchild once a week. She's fairly healthy. She has well-controlled hypertension. She delivered 3 children, and her medication is only metoprolol. And I think we all know what this means, that if we want to prescribe antimuscarinic drugs, well, then we have a problem, because if we have an antihypertensive drug already in the patient, then we are already limited in our choice. This is the voiding diary of Mrs. Robinson. She goes to the toilet 11 times per day. She has small and frequent voids. Her functional capacity is 265 mils. She has 3 to 4 incontinent episodes, uses 4 pads per day. Thinks she does not void very empty. She's tired. She looks tired, as you can see, because she has nocturia, and the urgency influences her daily life. She has also some prolapse complaints, and she had already tried lifestyle changes, antimuscarinics, but that did not give her much relief. Now my question to you is, what do you think of a daytime frequency of 11 times in a lady of 50 years, and how about her functional capacity of 265 mils? So I just want to have some answers here, whether daytime frequency of 11 times is too high, and whether her functional capacity of 265 mils is normal. So you might respond in the chat. Okay, I see some very intelligent answers here. And I think Adrian Wack is raising some point, whether it's entirely subjective, or whether she thinks it's excessive. But we have some data here, and I shall start sharing that with you. So this is, for me, this is interesting. This is from a thesis from Ernst van Haast. He's from the Netherlands, and he looked at voiding patterns and voiding frequencies in healthy men and women. 1155, that's not a small number. And if you look at men who are 30 years old, how much daytime frequency and nighttime frequency they have, this is what we might expect. 6 times during the day, half a time during the night. But if you look at the functional capacity, then we see 330 here. That's not very much. And perhaps this is normal, but we all think that because of our hemodynamic investigations, where we fill up to 500 mils, that this is a small number. Well, if you go down, men 70 years and older, 8.5 times during the day, 1.6 during the night. Functional capacity or volume voided, 209 only. Women of 30 years old, that's not Mrs. Robinson, she's halfway there. 6.9 during the day, 0.7 at night. Voided volume, 274. Women of 70 years and older, 8.2 during the day, 1.5 during the night. This is about 10. And the functional capacity here is 240 mils, or the mean voided volume. So what we might think is not that much, perhaps is normal in a patient life. And for that, I have to congratulate Dr. Wack with that remark, because that perhaps is not very excessive. We come to physical examination. She has a normal estrogen status, no palpable masses. She has a prolapse stadium 2. That means that in popular terms, the AA point is at the hymen ring, so 0 centimeters. There is a hypomobile urethra and a loss of 1 drop of urine when she's coughing. Laboratory investigation, all was normal. We did uroflowmetry in her, Qmax of 8, voided volume 165, residual volume urine 85 mils. And I think now we have a problem because we have some things that we don't like that much when we are starting treating this patient. So the questions about Mrs. Robinson, and if you want, you can answer in the chat. Do we need additional diagnostics? What are other treatment options? Well, we have many options. We heard about that. We have drugs, more drugs, PTNS, botulinum toxin A, sacral nerve stimulation, or even bladder augmentation. In which order should we give this treatment? Or do we treat the pelvic organ problems first? So please, if you have some idea, let us know what your opinion about this is. Some more data. If you look at the famous Rosetta trial, this is what was seen. An RCT in about 400 women. We gave botulinum toxin in these women, 200 units. That's where the discussion started, because in non-neurogenic patients, this is quite a lot. Or sacral nerve stimulation. As a result, we can see that the clinical response, which was defined as more than 50% reduction of urgency urinary incontinence episodes, was similar in both groups at 1 month, 83 versus 84 at 1 month. But that was not the primary endpoint. At 6 months, the change in mean number of daily incontinence episodes as compared to baseline, that was the primary outcome, was greater in the injection group. So Botox had a better effect than SNS. -3.9 versus -3.3 episodes per day, which was statistically significant. Perhaps clinically, that might be debatable. There were more patients dry in the Botox group, 20% versus 4%, which was significant, but also a bit strange to us, because we know that, well, we know, but we see in other series that the dry rates in both groups may be higher. Looking at more than 75% reduction in incontinence episodes per day, that was also higher in the Botox group as compared to SNS. And the treatment satisfaction was higher in the Botox group. So if you look at these data and then you go back to Mrs. Robinson, then you might think, okay, she's suffering from nocturia, she's suffering from urgency and urgency incontinence episodes. We want to give her the best treatment. We go for botulinum toxin injections. But then if you look at adverse events, urinary tract infection, and CRC is higher in the botulinum toxin group. And I think we may expect that, especially with her profile, she has prolapse complaints, but also residual urine after voiding, that this might be a problem. So how to choose? It's not that easy. Moreover, if you look at a 2-year outcome, looking at the urgency incontinence episodes after 24 months, then we can see that SNS was possible to be programmed throughout 24 months, and 2 additional botulinum toxin injections were allowed after 6 months. And then you see that there was no difference in decreased mean number of urgency urinary incontinence episodes over 24 months, -3.8 in the Botox group and -3.5 in the SNS group. There were no difference anymore in urge urinary incontinence resolution, whether be it 100%, 75% or more, or 50% or more. What was seen was that the botulinum toxin group maintained a higher satisfaction rate throughout the whole study, and also recurrent urinary tract infections were higher after the Botox injections, 24% versus 10%. Again, 6% required CIC post second injection. Adverse event of SMN, revision and removals occurred in 3% and 9%, respectively, which is acceptable, perhaps a bit comparable to what we see with the botulinum toxin group, but we also have to question ourselves what to do next. So I think that if we look at these data and we think these are the best data we have, then we might find a solution for an index patient. But in a patient like Mrs. Robinson, that is perhaps not a good option. Perhaps we could go for sacral neuromodulation first in order to avoid CIC. We have to discuss with her whether CIC is possible and also whether they are willing to learn that. Moreover, if you look at her other medication, we know that we are more or less obliged to give her antimuscarinics instead of beta-3 agonist because that is more safe in patients with hypertension, although this one was well controlled. So I think this is the start of a discussion, and then we can, based on the chairmanship of Veronique, try to answer the questions that are occurring now.
Thank you very much, John. Thank you, Arun. Would you like, because there are a few comments on the last questions you've asked about if we need further investigation in Mrs. Robinson or not. And some of our the people who are attending the Euro webinar suggest to perform, for example, a cystography or to an ultrasound in order to measure the bladder wall thickness. What do you think?
You mean in the case of Mrs. Robinson?
Yes.
Well, my idea in her case would be two things. First, of course, she has overactive bladder complaints, but she also has a prolapse, which is, like always, more or less on the limit of being operated upon or not. We know from our gynecologist colleagues and also from the urologists who do prolapse repair that you can operate on a stage 2 prolapse, but perhaps that's not the wiser thing to do. So the first thing for me would be that we consult the experts in the field here, which in our country are urogynecologists, to ask two things: whether the prolapse is causing her post-void residual, because I think that's one of the hampering features of Mrs. Robinson here, and also when they treat it, whether they treat as well the post-void residual and also the overactive bladder complaints. That's first. The second, imaging, yes, in this case perhaps, if you think that her prolapse is giving her too much let's say, emptying disorders of her upper urinary tract, I think a very straightforward ultrasound of the kidneys to start with would be an option for her. But I'm happy to hear what Arun says.
Yeah, well, I wouldn't rush immediately to do urodynamics personally at this stage. I think there's a lot more things that we could consider. First, I think, John, you mentioned she also has 4 pads and is complaining of incontinence. How much is that is coming from stress is not clear to me. So I think it will be worth sending a for pelvic floor exercises that might help her prolapse symptoms. It certainly will help her stress incontinence symptoms. And of course, she has overactive bladder. I understand she's on metoprolol, but I think, if I'm correct, if the blood pressure is well controlled, and I think the guidelines are suggesting that as long as it's not very high, 180/110, there's no renal impairment, so she should have a renal function blood test, we could consider mirabegron. And of course, we'll have to monitor her and check her blood pressure, but I think there's enough cardiac safety, I think, that we could consider that. So I would rewind back a bit: pelvic floor exercises, mirabegron, and review. And we could, of course, like you said, I completely agree that we should check with our urogynecology colleagues. I would like to see 1 or 2 more residuals, just to see if that residual is genuine. And of course, if we really, it stays up, it stays high, we could consider even a temporary pessary if she's in agreement to that, just to see the impact. To see whether that does going to help the overall thing. But I would be a little bit careful about doing too many things at once. So I would probably start with pelvic floor and mirabegron, and then consider urogyne and prolapse, but I wouldn't do urodynamics, not yet.
And then, there is this usual questions about if we have to perform urodynamics before offering botulinum toxin A or sacral neuromodulations. Do we have any evidence in the literature that the presence of detrusor overactivity may impact on the outcomes of these 2 therapies?
That's a very good question. I think we know from sacral neuromodulation that there is no relationship with urodynamic result and clinical result in our patients. So we cannot predict whether urodynamics, let's say detrusor overactivity, will respond better to neuromodulation than no detrusor overactivity. And also, if there is urodynamic improvement, it doesn't mean that there is clinical improvement. So I think for sacral neuromodulation, it's not known, and it's not very useful. For botulinum toxin, I think that we know from, I think, Eric Rovner's study that the patients with detrusor overactivity did not have better results on botulinum toxin or worse results on botulinum toxin than the ones without. That's a study that was done in the beginning, and I think it was part of the registration study. Perhaps there is more truth in that, but I think in this case, if you have a patient with post-void residual already, then the chances are higher that that might increase and that might cause or lead to self-catheterization than if she would void perfectly with a good Qmax and without post-void residual. And that means that perhaps the urodynamic will not give that much predictive results, but if you have this finding already, then you should discuss with her what the consequences will be or might be of whatever treatment, and that should be taken into account. This is about quality of life. This is not about a life-threatening disease or a neurogenic patient who needs to have protection of the urinary tract. This is another case, and that we always should have clear in mind.
Yeah, I'd just like to add briefly that if you look at the licensing trials for Botox, anyway, there was no urodynamics in those phase 3 trials. So they didn't, patients, that was not a prerequisite. They recruited patients with overactive bladder wet. And in fact, the licensing is for OAB wet as opposed to detrusor overactivity. Completely agree with John on the data. The phase 2 data didn't show a difference whether you had DO or not. And in fact, we are just waiting the results. In the UK, there's been a multi-center study exactly to answer this question called the Future Trial, which has been run by Chris Chappell and Mohammed Abdul Fateh. Multiple centers in the UK randomizing patients to urodynamics or office-based management who have refractory overactive bladder to look at the outcomes in the long term. So sadly, we don't have the result of that just now, but it's very imminent. So I think that will help inform utility here. On a personal level, I think urodynamics adds other utility. It helps me counsel patients better. It tells me in men if they have outflow obstruction, in women if they have stress incontinence, some other subtle things that that you may not have gleaned from the pure history or from the patient themselves. So I think I find it useful in terms of counseling.
Thank you. And Arun, you have introduced a very interesting idea, which is, the high rate of discontinuation in case of botulinum toxin A injections. And do you have, both of you, in your mind, a cohort of patients that you re-inject with botulinum toxin A injections after 2 or 3 years? Or what's your experience about that? What personally, I think after 1 year, I just lose them. So I don't know what's your experience about that.
I have experience with that. We have patients that are injected for 6, 7, 8 times. We also have the experience that many patients stop with botulinum toxin A injections. And I always wonder why. Because if it is very efficacious, so they have less incontinence, they have less voiding episodes, they don't have to do self-catheterization, why do they stop the treatment? Is that because the injections are too painful, too cumbersome, whatever? Is it something else that makes their complaints worse, or do they don't care about incontinence or the number of voiding times per day? So that's still a big question mark for me. Also in neurogenic patients, because for that we give it for a different reason, I think. For that we give it because we want to have reduced bladder pressures, we want to protect the upper urinary tract. So there it should be, I think, more than normal that we continue with the injection there. And there also, it's not always the case that they continue. That's a strange thing. On the other hand, what we know from the series, and I also thought I could read that very much in Arun's slides, of course, the 6th and the 7th injection, or the 6th or the 7th year of neuromodulation is as good as the first year, but that's only for those who continue with the treatment. So if you start with 200 patients first, and after 7 years, you only 15 left and they respond well, you missed 185 somewhere. So what happened to those? And why did they not continue? So there might be various reasons for that. But I think what we see in these long-term studies is a lot of self-selected series, which perhaps is not the best reflection of reality.
Okay, so I think we've got time left for one question. I would like to ask you questions about money. That we are very annoyed with our administrative things, etc. What about cost effectiveness? What do you think about all these studies about cost effectiveness, comparing these two therapies? Does it make sense or not? Because usually we said that Botox is most cost effective in the short term, whereas sacral neuromodulation is more cost effective in the long term. Does it make sense? Is it important? What do you think about that?
I think what you said is right. I think Botox in most of the cost-effective studies has been shown to be good in the short term, and I think the reasons for that are obvious. The outlay is pretty low and minimal, whereas with neuromodulation, the device cost itself is, it's really quite expensive. So it's understandable that you only may get benefit in longer term there. I think, for me, the studies that I've seen are all in different countries. That's the first thing. And every country has their own unique healthcare system with its own sort of challenges. In general, if it's expensive somewhere, it's going to be expensive everywhere, but it is subtly different between the different countries. So I think we have to consider that. I think with everything, I think innovation drives costs down. The more and more innovation we have, more and more companies coming out with products. You know, we hope that we may see potentially a reduction in costs on the neuromodulation side. That's my view. I think it's definitely one that you can argue that it is beneficial, but it is in the long term for neuromodulation. That's been the biggest difficulty in selling that therapy to governments and systems like that. You know, we in England, it's a very different system now. It's all centrally commissioned, which is in a way, it's really helped access in my country, because access to neuromodulation has been terrible traditionally. And that's why I said in my talk that it's important, if you're interested in therapy, patients get referred, because not a lot of people are doing it, at least in my country.
Yeah, there is hope, I think. We have these rechargeable devices coming up. That makes that the life expectation of these devices will be longer, and therefore the cost should be lower. I also think for botulinum toxin, the biggest benefit that we had was that we could do it on local anesthesia, which makes it far less expensive than if you have to do it on the OR. Perhaps also new devices, new competition that will come in will reduce the price. And what I'm always surprised by, the same devices that are used, for instance, for pain medication or pain treatment, there the devices are used far more shorter than what we experience in urology. Still the prices are higher, so the change of systems there is far more frequent than we have, which makes it relatively cheap to have neuromodulation for urology. But that doesn't mean that that it is cheap enough for the payers to accept it everywhere. So it should be better, it should be improving cost-wise, but we are not there yet.
Okay, so time is running fast now. So I just would like to thank John and Arun for their talk and their expertise. I would like to thank the participants for your very active involvement in this webinar. I just would like to remind you that this webinar is accredited with the 1 CME point, and that you will receive an email with the link to the questionnaire tomorrow. And at the end, I would like also to tell that this activity was supported by an educational grant from Medtronic, with no involvement in the program or speaker selection. So thank you. Thank you, John. Thank you, Arun. Thank you, you all. Bye-bye.